Good morning. I'm Nivi. I'm one of the PGY1. So like David said, I'll be talking about oral blocks this morning. Specifically, I'm going to review indications and contraindications to doing the oral blocks, nerve distribution to help determine which blocks you're going to use. There are a lot of oral blocks, so I'm going to review just a couple of the more common ones that we might do in the ED, and then go over some of the complications. So just to start with the case, while I was on PZD, Dr. Shaw and I had a 5-year-old male who fell while he was playing outside. He presented to the ED with a 4-centimeter laceration in the mid-tongue. The laceration did not go through and through, so we felt like we could do the lac repair in the ED without calling OMFS. Otherwise, the patient was stable and had no other injuries. So while oral blocks may not be the most complicated procedure we do, I felt like it was important for us to review because I feel like we do get a lot of patients who come to the ED complaining of pain or other oral trauma. And I do feel like it happens a lot after hours and on weekends. And I know at King's we do have OMFS colleagues, but if we're ever in the case, if we go to the community or if we're ever in situations where we don't have OMFS, I felt like it would be important for us to know. And then I also know Fast Track gets a bunch of dental pain. So oral blocks are a simple and efficient way for us to do pain management without using narcotics. And like I mentioned, it's useful for us to be doing oral blocks to help do procedures. Oral blocks can be divided into 3 different types: your local infiltration, a field block, and a nerve block. Local infiltrations anesthetize the terminal nerve ending of the dental plexus. So this is helpful for if you're trying to target a specific tooth or a specific area in the mouth. Field blocks anesthetize the terminal nerve branches in the area that you're trying to treat. So if you do a field block, you can do procedures that are slightly distal to the area of injection. And then finally, the nerve blocks anesthetize the main nerve. And so this allows you to numb an entire region and do a procedure in that region. Reasons we do oral blocks include abscesses, trauma, lacerations, like I mentioned, toothache, post-extraction pain, and also you can do it for mandibular or maxillary fractures. Contraindications for oral blocks include like the obvious ones, if patient has allergies or if they do have any bleeding disorders. But other things to think about is if any patients have distortions over the landmarks where you would do an oral block, or if there's an infection overlying that site. Okay, so to review the anatomy, when we're doing oral blocks, you're targeting the maxillary and mandibular branches of the trigeminal nerve. So the maxillary nerve provides sensation to the maxilla, including the maxillary teeth, gingiva, and oral mucosal membranes. The mandibular nerve divides into 3 branches, including the long buccal nerve, which does sensation to the cheek and the buccal gingiva of the mandibular molars. The lingual nerve that provides sensation to the anterior 2/3 of the tongue, the floor of the mouth, and the lingual mucosa. And then finally, the inferior alveolar nerve. So this also in and of itself divides into the mental nerve, which innervates the lip and chin, and the incisal nerve, which innervates the teeth and gingiva. So I found this figure super helpful when I was trying to figure out how to do oral blocks in peds. It can, based on where your tooth pain or injury is, you can use it to figure out which oral block to use. The most common oral blocks include the supraperiosteal, inferior alveolar, superior alveolar, infraorbital, and mental nerve blocks. In terms of the anesthetic, there are a couple of options. I listed the lidocaine and bupivacaine as those are the 2 most common. Bupivacaine, in this table, you can see right around here the duration of time. So bupivacaine has a longer action. It does take a little bit longer for onset, but a longer time for numbing. And so this could be useful, particularly if you're trying to help with tooth pain. During my review of the procedure, I also saw that a lot of the literature recommended doing topical anesthetic over the site that you're trying to numb. So you can use this, you can do this either with having a patient do swishing viscous lidocaine if they're able to, or you can take either gauze or like a cotton tip applicator and apply it directly to the site of where you're going to inject. So like I said, I'll review just a couple of the most common blocks we use. So the supraperiosteal, this is to anesthetize either the anterior or middle superior alveolar nerve. Again, to review the anatomy, the anterior superior alveolar nerve provides sensation to your medial and lateral incisors, your canines, and then sometimes the first premolar. And the middle superior alveolar nerve provides sensation to the premolar, canine, and first molar teeth. When you're anesthetizing with the superior osteal infiltration, you're going to inject against the periosteum of the alveolar ridge adjacent to the tooth. So it then infiltrates the periosteum, the cortical plate of the maxilla, and then the medullary bone to get to the nerve root. So for the supraperiosteum infiltration, it's best to do on teeth that have thinner cortical bone. So the maxillary molars and your mandibular teeth have like thicker cortical bone in adults. And so it's harder to do this block and have it be effective. In children, these areas the cortical bone is all supposed to be thinner, so you could potentially do it for them. In order to do this block, you're gonna find the mucobuccal fold overlying the tooth that you want to anesthetize. So you use your non-dominant hand, lift the lip up and outwards, find the mucobuccal fold in the spot that's directly centered over the tooth that you wanna anesthetize. And here you can inject going like 1 centimeter to 1.5 centimeters in and inject 1 to 2 cc's here. Things to remember for this block and any block in general is if you are injecting too superficial or too deep, you're not going to be in the right location. And so you might not anesthetize appropriately. And then also once you do inject the solution, it may take up to 10 minutes for the patient to become numb. The inferior alveolar nerve block. So this is, you're anesthetizing the ipsilateral side of the mandible, as well as the lip and chin via the mental nerve. So to do this block, you're ideally gonna stand on the opposite side of where you're anesthetizing. And with your hand, just place your hand inside, pull out the cheek and with your thumb, and your index finger or the rest of your hand should be positioned externally behind the cheek at the posterior ramus. With your thumb, once you do pull out the cheek, you're gonna feel back for the retromolar fossa. It's kind of where the needle is pointed at in the right picture there. That's your coronoid notch. And so your needle from the opposite side is gonna be pointing towards this area and past the lingula, which is the medial surface of the ramus. The barrel of your syringe, if you look on the picture on the right, should be between, like overlying the first and second premolars and directed towards the opposite side. So when you get into that position, you're gonna insert just superior and posterior to the lingula, go in until you feel the ramus of the mandible and inject 2 milliliters of the solution. In patients who can't fully open their mouth, so in situations like if there's an abscess, edema, or trismus, you can use the the closed mouth approach, which actually deposits the solution a little bit superior to the site of the open mouth approach. So when injecting, you're gonna place the needle along the maxillary teeth and gingiva that you can see sort of on this picture on the left. And you're going to advance, once you get to your position, it's going to be just medial to the ramus of the mandible. You're going to advance the needle about 3 centimeters, and then again, you can inject about 2 milliliters of the solution. Because of the proximity of the inferior alveolar nerve to the lingual nerve, you usually end up anesthetizing both when you use this procedure. And then finally, the infraorbital nerve block. So this can be used to anesthetize the lower eyelid, upper cheek, part of the nose, and the upper lip. So to do this block, you're gonna identify the infraorbital foramen within the patient's mouth. It's at the intersection of the mucobuccal fold over the first and second premolar. So you can place your index finger along there to help identify where you're injecting. Once you're there and you inject, you're gonna wanna aim your needle in parallel to the axis of the second premolar. Here you inject about 1.5 to 2 centimeters in, and you can put 2 to 3 cc's of the anesthetic there. When I was reviewing this procedure, it was recommended that you apply firm pressure externally on the patient's face so that you're not causing any edema to the lower eyelid. And then also you can massage in the anesthetic at that site. Similar to the inferior alveolar and lingual, the anterior superior alveolar nerve is proximal to the infraorbital nerve. So when you do this block, you could potentially be anesthetizing the anterior superior alveolar nerve as well. So with regards to complications, some of the more severe complications tend to present rapidly. So this can include allergic reactions, cardiovascular and neurologic toxicities. I did see seizures listed as well, and injection into the carotid artery. So some ways to help avoid doing this is to remember to aspirate before you start injecting the solution. Important to get history from the patient about bleeding risks and then prior incidences with anesthesia. And then also important to be calculating how much of the anesthetic you could be giving based on their weight. Late complications include hematomas, neuropathies, infection, and trismus. So hematomas, again, are if you inadvertently puncture the artery or vein. Arterial hematomas tend to enlarge pretty rapidly and can be more painful for the patient. Again, it's important to know if the patient has any bleeding risks or are on blood thinners, but if they're not, usually the treatment is just supportive. You can apply cold packs, and then I read that after 24 hours, you can apply a heat pack to help break down the hematoma. Peripheral neuropathies usually present as like prolonged anesthesia, paresthesias where they feel burning or itching, or hyperesthesias where it's increased sensitivity to noxious stimuli in the area. This can usually result from traumatic injection of the needle into the nerve if you're injecting directly into foramen and causing like a tighter space around the nerve, or if you inject into the nerve sheath. So again, what I read for ways to help avoid this is if you actually inject, before you inject, if you pull back on the syringe, and if the patient starts to feel a shocking pain, and to tell you that there's potentially that you're going to do a traumatic needle injection. And then finally, for infection, it tends to be rare for these procedures. However, it can happen. Important things to remember is, again, don't inject into a site that has infection, because you have the risks of seeding the infection into the surrounding structures or causing bacteremia. And then also trying to do our best not to inject multiple times in the site. So just to wrap up the case, with this child, because the laceration was all the way across his tongue, we did a bilateral inferior alveolar block using lidocaine, which was long enough for the procedure that we needed. And we were able to do 5 observable sutures bedside. These are my references. At Shante, thank Dr. Kendall, Dr. Turner, Warshaw, and Dr. Chu for their feedback. Any questions?
A couple comments. That was very good. It's an important topic. So one is I urge people to have a selected, you also have an elective. And one of the things you can do and spend a week is to spend a week in the dental clinic. And they're very good. We have to deal with them. They send their dental interns to us to fast track because they're required by their own ACGME or whatever it is to have that experience. So in return, they're very happy to take you guys. And you go for a week and they'll teach you the blocks, and you'll do them on patients with them, and they'll let you do them eventually with them standing there. And they'll even let you pull teeth if you want to do that. So I urge you to kind of think about that when you do your elective and selective. The other thing is that when the dental interns and the oral surgeons are in the fast track and in the ED, especially there's more time in the fast track to do it. We urge you to go in with them when they're doing an access and they're doing blocks, and they'll let you do them with them and even show you. And part of our deal with them that Dr. Willis worked out with Dr. Levine is that they will go in when you're seeing medical kind of cases, and ortho cases, and trauma cases in the fast track. In return, when they go in and see and take care of an abscess or take care of a lac inside the mouth, you go in with them. And that's perfectly fine with us in the fast track. You don't have to say, oh, I got to see another sore throat, or I have to see another sprained ankle. No, if they go in, you go in with them, and you learn, and they'll show you how to do the blocks. We say in Yiddish, one hand washes the other, and both hands wash the face. So you help each other.
own sterilization kind of area for all of the equipment that they use, thinner, longer, flexible needles, ampules of the anesthetic tubes that are up. So during the day, if you want to be doing blocks, obviously we can get all the lidocaine stuff that we have, but you can also call over there. They've always been very nicely to let you walk over, get a tray, with all the equipment and the ampules, do my block, do my thing, and just bring the tray back. So obviously, then I'll just try to walk over there and pick it up, but it's just a little bit easier to use the needles, and then they have all the anesthetic there, and you don't have to worry about them. They've always been nice to me to let me do that.
I think especially for kids, it makes a big difference.
Yeah, big difference.